Hello, everyone. Welcome to Problem Solved, Fixing Last Mile Engagement in Healthcare, the show where we dig into what's not working in healthcare delivery and explore solutions that actually make a difference for members, patients, payers, providers, and other healthcare organizations. Today, I'm really excited that we're joined by someone who knows the space really well and inside out, Tom Cassels, Managing Director at Manatt Health. Tom has spent his career advising health plans, providers, systems, policymakers, and innovators on strategy, growth, innovation, and transformation. He's worked with some of the largest and most influential organizations in healthcare and some of the most well-known innovators who've had real impact on the space. And more importantly, he's been a candid voice on what it takes to truly improve the business of care. Tom, welcome to Problem Solved.
Thank you so much. I'm really grateful to join you today.
This is super. So let's just jump right in. You've advised plans, policymakers, providers across the board. Are you bullish or bearish on the future of Medicare Advantage for the next 5 years?
I'm bullish. And the reason that I am bullish really has to do with a couple of things. One, I spend a lot of time working in both the payer side, but also the senior living side. And one of the things that makes me really optimistic is you can't divorce what a plan can do from what a plan can know about the life and the physical surroundings a member. And increasingly, through my work with the National Investment Center on senior housing and care, there is a connection between the Medicare Advantage program and the senior living communities that I think is going to be really critical. And I think, frankly, longevity itself is going to be critical to the Medicare Advantage world. I think we're going to see a lot of change in the demographics of Medicare Advantage and the influx of the 65 to 75 age group being healthier than historically it has been, and a larger 75 to 85 year old population is going to play into the strengths of what I would call Medicare Advantage plans that run toward the fires. So folks who are really working in models where providers are accepting risk, where members are engaging with their primary care. And I think both of those things makes me bullish. I think if I was, an equity analyst, I might feel differently. I really don't see the current financial vicissitudes of the program having a material impact over the next 5 to 10 years.
That's great. You said a lot, and we'll unpack that in the follow-up questions. Let's start with the enrollment side. The base enrollment keeps growing in healthcare. MA, Medicare Advantage saw what's it now? Almost 35 million, just shy of 35 million people on Medicare Advantage. That's grown at about 4% last year, a little less than the previous years, but still at a highly respectable clip, and it continues to grow. But financial costs and regulatory scrutiny is rising right now. From your perspective, how should the model change? Is it an inflection point? What's got to give?
Yeah, I think part of the change that is necessary is what I would call a history of bidding for members at all cost, is inconsistent with being successful in the marketplace. I think what you've seen is the folks who haven't had to pull their earnings have been the folks who have most aggressively shrunk their Medicare Advantage footprint. This is not special to Medicare Advantage. From time to time, the market dynamics of every market change, and you have to realize what are, for you, the where to play, how to win choices. I do believe that there are some pretty significant plans who are more likely to be successful in in the younger, less complex populations, and there's room for that. I also think that there are plans who are well designed and perfectly adapted to more complex populations, and the way that we see the rotation of kind of profit margins going forward is going to be a reflection of right plan, right population. And I think as you see that that rotation, I think regulators are going to rightly reward people who are meeting their members where they are, and not manipulating necessarily the underlying risk factors that can be found but are not material to the risk pool that you're going after. So there's almost a bifurcation of high risk Medicare Advantage players who are probably much more vertically integrated, who are much more focused in the markets where they operate, versus generalist plans that look an awful lot more like exchange traded plans. And so I think as people in these plan leadership positions stake out their place in the market, I think the regulatory scrutiny will justifiably sort itself out, but that just hasn't been the case in the last 5 to 10 years. I think the last 5 to 10 years has been any membership is good membership.
Right. That's a great point. The right plan, right population matching matters, and it is obviously getting that right has both financial and regulatory benefits. But the risks, but if you look at where plans are right now, utilization has been going up. So that's utilization. Healthcare utilization has gone about 20% roughly in the last 5 years, and plans are struggling with it, the financial hit that they're facing. So they're going to say, this approach of risk adjustment, understanding the costs so you're covered, it makes sense. So how do you, so that's one side, but the other side is that plan designs and benefits may not match specifically utilization drivers and the demographics of what you're saying. How do you, what's your advice for plans when they face these two challenges?
My advice for plans, and I think this is kind of I I would call it uh, the hard gravel road. Uh, you know, benefit design that is not structured to meet members upstream uh, of costly and unnecessary utilization. Those benefit designs are going to be a recipe for uh, you know high 80s, low 90s continuous MLR. Uh, we we have not. We've leaned pretty heavily um, on top line and not nearly heavily enough on what are the factors that are driving what I would refer to as kind of index events in a member year. A unnecessary ED visit that turns into a complication and an inpatient admission. A lack of uh, uh, annual wellness visit that allows a condition that, frankly, we know about to increase in severity, and lack of an annual wellness visit with a true kind of honest dialogue between patients and physicians, and then between physicians and payers about what are we hearing and what are we not hearing um, from the perspective of health related social needs. And the more that we are moving upstream, which does incur cost, the more likely we are going to see some of the uh, unnecessary costs, uh, uh, deflating. And I think that's probably the most important action that we can take on the plan side, and that's not necessarily something that is uh, you know a core competency of plans to date. It's also politically uh, a little bit of a hot button issue, but it's not as politically hot button as uh, not being able to forecast earnings for 3 years.
Right. But there is a precedent, actually. There's something that they've faced in the past. It may not be a core competence in the Medicare space, but for healthcare, um, plans in the commercial space went through this in the aughts and the early 2010 onwards, in the last decade, where costs were insane, climbing, and they had to really reinvent how they delivered care in the commercial employer space in the ASO market. And lots of innovation. You've seen Hinge Health and organizations that came out of that adoption has made a big difference. You've said something that I wanted to point out. That you've mentioned that to grow, plans must become care managers again. And I think it's about a little bit on the same vein. What's in your mind an effective modern care strategy that and how will it look in practice for a Medicare organization looking to adopt that?
I think one of the things that I think is going to be a new to this environment approach is how we think about uh, the integration of reimbursement for mental and physical health.
Mm-hmm.
Uh, right now we have separate systems for behavioral health, for medical spend, for pharmacy, for dental, for vision, etc. All of those have one thing in common: the human body. Um, and if we carve it up, we may optimize for those individual business lines, the carved out behavioral health services, PBMs, etc. I don't think that that's a successful model for for moving forward. It is extraordinarily difficult to manage the CHF of a patient who is in a manic depressive state, and it's really hard for me to believe that a prepaid model for an episode of major depressive disorder isn't going to have a downstream impact on the physical health of, of a member. So I do think that we're going to see care management not in the siloed models that we've seen. We're going to need to see an integrated care management system, and I think the integration of physical and mental health is as important as the integration of medical care management and polypharmacy. Uh, there is a huge disadvantage to health plans who frankly fight over whose job it is to solve a medical problem that exists because of a polypharmacy either oversight uh, or, uh, or lack of adherence. And it's kind of like that Spider-Man meme where everybody is pointing at one another, when in reality, the member is the member. And so I do believe that we have to take off our Spider-Man outfits and put on an integrated uh, approach to the impact that pharmacy has on the medical book of business.
Right.
So those are just a couple of examples of where I see care management changing for the better. And if we don't make those changes, um, we'll just be very, very weakened organizations with expensive AI agent call centers.
That's right. And the point that you made earlier with your experience, you mentioned the National Investment Center for Senior Living and Caring. Congratulations, by the way, you just joined the board.
Oh,
And
excited.
The point around context is really important because you, as a Medicare plan and Medicare Advantage, you have the member for the rest of their lives, essentially. And whether they're with you or not, it's the same member. And the context around mental health, physical health, pharma, understanding the context around the individual can really help drive and think through how to provide effective long-term care. And you, as a plan, have the right incentives. Uh, when you're not doing it, you see it show up in the as a plan. You're also measured on quality, and so it shows up in the star ratings. We've seen, I would say, more than a gradual, it's an accelerating decrease in star rating quality across the past few years. In fact, right now, from COVID, since COVID, but now the average star rating is less than 4, which is the golden number where you could start getting
Mhm.
benefits and rebates. Um, how do you see the care management, the holistic view applying for organizations thinking about their stars, and how do you improve quality as a payer? Do they have to work with providers? How do you what would you advise organizations as they think about, is it do it yourself, do it with others?
Yeah, it is definitely not a do-it-yourself activity.
Yeah.
Um, and I mentioned the the greater alignment there is between health status, the perceived quality of your health insurance, and the quality of your housing and personal finance. I think retention is such a big part of the business models of both Medicare Advantage plans and senior living facilities across the uh, acuity spectrum, that those are natural partners. I find that, frankly, if you are not working, for example, with uh, uh, the senior living community, it's really hard to know where your members really are. Uh, if if I mean, I have clients in the Medicare Advantage space um, who, the minute I started working with Nick, um, the first question they had was, can we get Nick map data on where our members are across this space? Um, and I really think the the other consideration that we don't take into account is caregivers.
Right.
I think you know there is, for the positive, conversation in the administration and on Capitol Hill to take into account the caregiver experience, the caregiver intelligence that is going back and forth between plan, physician, and caregiver. You know, that we have been so focused, or plans have been so focused on their physician partners, that I think they've forgotten that 99.9% of Medicare Advantage members' time is spent where they live or with their friends, family, and caregivers. So I think there are multiple channels that need to be viewed much more aggressively as active partners in in being successful when it comes to the STARS program. And I think one more group I would add to that is pharmacists. As we see um, the quality scores associated uh, with polypharmacy and uh, medication adherence, you know, they those have drawn a lot of attention. I think the next generation is really going to be, uh, a focus on what is the service between pharmacists and members, that that you're enabling. And so I think that's another important partnership.
That's really valuable and insightful. In fact, we see this in the data at Predict Health. We see contextually how members live, who they live with, access to care, and there are spikes and changes, dramatic spikes and changes based on their and their take a measure. Adherence is a big deal. Drug adherence, program adherence, and communicating and engaging them effectively is a very powerful channel for STARS leaders, but also plans, but also for the other partners that they work with as they're looking to improve their care. And this leads to a point around CMS. So CMS is in charge, obviously, of creating the incentives. You have the STARS program. It's measured. There's a lot of dollars associated with getting it right and getting it wrong. Do you think CMS is creating the right incentives to encourage innovation in Medicare Advantage, or is regulatory complexity getting in the way?
I think it's very easy because we're such a highly regulated industry to cry complexity. If I would say one thing about the current administration's approach across CMS and HHS, it is to actually work with the industry rather than regulate first, ask questions last. Mm-hmm. It's up to health plans to opt in to partnering with CMS. And I think in the same way that you've seen health technology viewed as an ecosystem to really take some of the goals of CMS and push them forward, I think the Medicare Advantage space needs to also think about, well, where do we play with that ecosystem? How can we have the same kind of impact through being a part of making our industry stronger for members versus being told through a set of rules what makes the industry stronger for members. Because I truly believe the closer you are to the member, the more likely you are to have practical solutions. If you have someone asking you to help yourself, don't get in their way. Make that work. And I think that's an opportunity that is very real.
That's great. As I mentioned, you recently joined the board of the National Investment Center for Senior Living and Care, Housing and Care. How has your experience there influenced your thinking about the role of senior living in the healthcare ecosystem?
It's a very personal thing for me, having recently lost my mother to Alzheimer's, and kind of experiencing frankly senior living in the home with home health aides. Obviously, a different level of acuity. I think there is a dramatic shift that is occurring from a grassroots perspective but needs to move faster to recognize that healthcare is inherently a part of the business model of senior living, and that has not been acknowledged in the past. Senior living has been a real estate business, and I don't say that uh, to cast aspersions. Um, that that frankly is how the businesses have been financed. Um, it's not good enough, and it's not good enough for uh, the senior living communities themselves, but it's certainly not helping the the folks living in these communities um, to have a diet that expressly doesn't fit with their health needs when it is an easy opportunity to work with nutritionists, primary care physicians, health plans, um, to kind of really work on a collaborative approach to health in the home. And this is something that you've heard in the provider community for years. You know, the ultimate winner is those who are going to own the home, the last mile of care. I, I look at it from the opposite direction in my work with Nick, which is the first mile of care um, has to come the uh, from the member and and the occupant of the place where they live, and the caregivers who are either with those folks or visiting those folks. And I think if you can combine the power of your physical environment with your care environment, the opportunities are much richer to see both a better outcomes for individuals, but also to get back to that retention point, a clearer connection to what is the value proposition of living here and working with this health plan, because they work together and not at cross purposes. So I'm really hopeful for the fact that, frankly, I would be welcome on the board to bring that perspective, and I think there's a growing uh, number of operators, um, operator owned
Right.
MAA plans, special needs plans, operator owned medical groups, even that really are trying to connect housing and health.
And we see a lot of innovation there, starting from the PACE programs. You're absolutely right. The institution, the special needs plans, and it's great that you're actively now part of this ecosystem and thought leadership here. We are coming to the end of our podcast, and I wanted to actually turn it over to you. One last question is: if you could whisper one strategic imperative to every Medicare Advantage CEO in the country, what would it be?
There is there's every reason for for folks to be kind of reticent to do things differently than the pack on purpose. Um, what I would say is the pack is faltering, and what has gotten you here is actually what's causing you to falter. So instead of going back to basics, I would say be bold. Uh, and I think that that piece of advice is hard to, it's a hard piece of advice to take, especially when, you know, every quarter you're back in front of someone. But, but I do believe that the window for determining your success in the Medicare Advantage space cannot be quarter to quarter. And in some cases, year to year, as regulations and just underlying demographic shifts have changed the economics of the business. So, you know, what good leaders do is they act in the face of complexity, uh, and they don't wait to see where everyone else goes.
Right. That's great advice. Act boldly, and you heard it, folks. So, with that, thank you so much, Tom. Really, really enjoyed the
You,
conversation, and this has been great. And I look forward to the next conversation. Thank you.
absolutely.
Thanks, everyone.